Dear healthcare professionals, what I am going to share with you through this video is beginning of series of interesting cases which I came across during my clinical practice while working in ICU. Videos are helpful for all healthcare professionals. Here, I will share real cases those are presented to my intensive care unit. Though these cases were not critically ill but diagnostically they were challenging in the sense that diagnosis which appeared initially was not the final diagnosis and simple mistake of not making right diagnosis would have led to unwanted and unwarranted consequences in the patients. I will share the real stories and take you through real scenarios so you can connect these stories with real-life clinical situations which happen to these patients. So, let's embark on this journey of making the uncommon diagnosis and how it impacted the management and outcome. Let's begin with our first case. A 42-year-old man presented to hospital emergency with a few days' history of headache which worsens during upright posture. There was no other significant history including any history of trauma, fever, aura, vomiting, or any medication intake. On presentation to emergency department, he was conscious with stable vitals. He was seen by neurophysician and advised CT brain. CT scan brain was done in the emergency department which revealed bilateral subdural collection. After CT scan brain, images were shared with neurosurgeon. Neurosurgeon advised to post the patient for surgery next day morning. What is your opinion based on the given information? Whether treating team was moving in the right direction? Case was first seen by our team in the ICU. Our first reaction was, why bilateral subdural collection in this patient? We requested surgery to be kept on hold till we gather more information and diagnosis becomes clear. We reviewed medical literature for the causes of bilateral subdural collection in a middle-aged man who presented with history of postural headache and without any history of trauma and fever, and subsequently we planned for an MRI brain. MRI brain was done and subsequently we discussed the case with radiologists to look for the finding of spontaneous intracranial hypotension in MRI based on our review of literature. Our suspicion of spontaneous intracranial hypotension was confirmed on imaging. We canceled the surgery and referred the patient for further workup and treatment to a higher center. So, what could have been possible if we proceeded with surgery in this patient? Surgical drainage of a subdural hematoma, SDH, in patient with spontaneous intracranial hypotension can provide temporary relief from symptoms like headache. However, spontaneous intracranial hypotension is characterized by a leak of cerebrospinal fluid, CSF, which lowers the overall pressure within the skull. Draining the hematoma can further decrease the pressure, potentially worsening the CSF leak and leading to a recurrence of the SDH. This recurrence can manifest as a worsening of the patient's initial symptoms or even lead to new complications, such as brain herniation or stroke. If we proceeded with surgery of removing subdural collection, this situation could have worsened the patient condition leading to brain herniation. By establishing the underlying cause of bilateral subdural collection, hence, by establishing the correct diagnosis, we were able to prevent likely morbidity and mortality. So, diagnosis of this patient was not bilateral subdural collection but spontaneous intracranial hypotension. Bilateral subdural collection was a finding and postural headache was presentation. So, establishing a correct diagnosis is an essential component of treating patients. Misdiagnosis can lead to incorrect treatment, complications, and potential morbidity and mortality. Hope this was an interesting case. If you like this information, please subscribe to this channel for more interesting and challenging diagnosis.